Okay, so next we're going to talk about the urinary system. And we've got to do a little bit of anatomy review first, just so that everybody's remembers. But we begin with the vascular system. There are several hormones that influence whether fluid or electrolytes are retained or excreted in the urine. So remember that we have ADH, we have BNAP. So there are hormones that actually influence how much fluid we're retaining. Cortisol influences fluid retention. Several of those hormones are triggered by changes in our blood volume or our blood pressure. So if our blood volume or blood pressure decreases, hormones will actually send signals to the kidney or go to the kidneys and trigger increased reabsorption of water to increase the blood volume, for example. So remember the hormonal component, and you get a lot really deep into that next semester. The kidney itself is made of quite a few nephrons. We're going to go and look at a quick picture of the kidney, and we're going to go back and forth. So we have blood flow to the kidney, the nephrons, when blood goes through the nephrons, fluid and electrolytes are either put back into the bloodstream or back into the urine, one way or the other. And then the urine collects in the ducts and eventually collects and is moved by the ureters into the bladder. So now let's look at a micro image of that. And we're going to look at the nephron. So in those nephrons, we have blood flow. Here's Bowman's capsule, the glomerulus. We have the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and then it goes to collecting tubules and eventually is collected, and then those tubes get moved together so that we move the urine into the calyx of the kidney and the ureter. So in all of these various sections of each individual glomerulus, or each individual nephron, in all of those sections, different electrolytes are either absorbed back into the bloodstream or not. One really common example is that in the loop of Henle, potassium can cross that membrane. And so if we're giving diuretics that act on the loop of Henle, that patient tends to lose more potassium. So patients who are on Lasix are going to lose potassium, and they frequently need potassium supplementation. So that's just one of those examples. When you talk about diuretics, you need to look at what part of the nephron do they work on, because that's going to affect how well they function in patients with impaired renal function, for one, but also it's going to affect how those diuretics affect electrolyte levels. Okay, so that's the nephron. Now let's look quickly at the entire urinary system. And we'll talk about the function of urination. So nephrons, and then the urine that drains out of them actually goes into the tubes, become go together and get larger, and then it goes into the ureters that take urine to the bladder. The bladder is a muscular organ. And so when the bladder is full, it has stretch receptors. Those stretch receptors will send a message, hey, we need to urinate. And if the person finds that time and place convenient, they go to the bathroom and then consciously relax the urethral sphincter, the external urethral sphincter, and the bladder contracts for urination to happen. There are two sphincters on the urethra. There's the internal sphincter, and whenever we have the urge to urinate, that internal sphincter actually opens involuntarily. But if we suppress that urge, we can actually wait a while because we have the external sphincter, which is under voluntary control. For us to urinate, not only do we have to relax the sphincter, we have to have bladder contraction because that helps force the urine out. That's really important because if we have the bladder really relaxed, and there are some medications that do that, and there are some forms of paralysis that lead the bladder to be very relaxed or flaccid, then we can't urinate or we cannot empty the bladder fully. Now, we also have the other thing I want to talk about in relation to this is the pelvic floor muscles. Pelvic floor muscles are, let's just see if we can find a picture really quickly. Pelvic floor muscles are a set of muscles. I'm sure we can find a picture that support all of the internal abdominal organs. Here is a good image. So the pelvic floor muscles support the internal abdominal organs. If those muscles are weak, then we can have the bladder kind of collapsing into the vagina. We can have the rectum, bladder collapsing into the vagina. We can have the rectum collapsing into the vagina. We have cystocele and rectocele. The pelvic floor muscles also give some support to the urethral sphincter. So if we have weak pelvic floor muscles, we're more at risk for stress incontinence and urge incontinence because that urethral sphincter needs some help to contract and be able to stop the flow of urine. Okay, so I want to talk about the factors that affect urination. There are developmental factors. Most kids toilet train somewhere around 2 to 3, but full urinary continence is usually not found until or achieved until about 4 or 5. So urinary accidents are very common in small children. They don't realize they need to go until they don't have time to get there. Their bladder capacity is small, so if they're out, if they're away from a toilet, they may not have time to get there, things like that. Bedwetting continues into childhood for some children. Bedwetting is almost always 100% a physiologic problem. It's a combination of a bladder capacity that's small for the child's size, so their bladder capacity hasn't quite caught up yet, and ADH levels in adults and actually in older children decrease during the day during the night, other way around. ADH levels increase during the night while we're asleep and we hold on to fluid. So we don't urinate as much at night. But for some children, that increase in ADH production, actually is delayed. ADH is the antidiuretic hormone that tells our kidneys, hey, hold on to some fluid. That production increases at night, so we don't urinate while we're asleep. But for some kids, that's delayed. So kids who have a smaller bladder capacity and their ADH production hasn't really kicked in yet, and maybe they're heavy sleepers, are more prone to bedwetting. After 40, the prostate enlarges. That can cause urinary retention, incontinence, and UTIs. Pregnancy and age-related changes relax the pelvic floor, and that can cause cystocele, rectocele, incontinence, urinary retention, and UTIs. Elders have fewer nephrons and they lose muscle tone in the bladder, so they may have a harder time emptying fully. They have an increase in UTI because of that, and an increase in nocturia. There are some dietary things that can affect urinary health. Increased sodium may actually decrease water elimination. If we increase sodium, we may actually hold on to more fluid, so it can cause some swelling. Caffeine and alcohol are diuretics. There are some other diuretic foods that you may be aware of, things like watermelon or lemon juice. Fluid intake affects urinary output because urine is primarily made of water, and we need water to actually be able to eliminate those waste. So fluid intake is a factor in urine output. Immobility decreases circulation, and so we have decreased kidney perfusion. So a patient who's completely immobile is going to have some decreased kidney perfusion. It's also difficult for patients to empty the bladder in bed, especially if they're unable to sit. So that can contribute to urinary retention. Stress and anxiety can cause bladder spasms and urinary frequency. Patients may have difficulty urinating if they don't have enough privacy. Some patients really struggle to use public toilets, or some people. We also have a perception, again, in our really busy culture, a lot of people have a perception that they don't have enough time to go urinate. So we may decrease intake to compensate and get UTIs due to urinary stasis. Pain can interfere with relaxation of sphincters. Pain can actually be severe enough to cause spasms and the sphincter to spasm and not allow urination. Painful urination can lead to avoidance. So if it burns, then we may try not to go, which increases the UTI, the risk of UTI. Kidney stones are when there are deposits of different types of salts in the kidney that collect in stones, and then they can't, they shape to wherever they are made, and then they can't move easily through the urinary system for excretion. And so when they start trying to move, that can cause pretty severe pain. When patients who have arthritis or who have other chronic pain issues may actually avoid urinating frequently enough. And a lot of times when people are not wanting to void, they don't want to go to the bathroom, they'll decrease fluid intake. So chronic pain can increase that also, which increases retention and UTIs. Surgical procedures, usually we have some decrease in perfusion during anesthesia because it lowers blood pressure, and so there's decreased urine output. We also have immobility, which can decrease urine output and make it more difficult to void, and there are meds that cause urinary retention. Lower abdominal surgery can cause inflammation and swelling in those tissues, and that can actually lead to retention or obstruction. There are medications that affect urination. Diuretics are clear, and we talked about how diuretics work in different parts of the nephron. Any medication with an anticholinergic effect, so think about anti-nausea meds and antihistamines, those are going to cause urinary retention because they relax the bladder. So they make it harder to contract the bladder and be able to void. Any sedating meds relax the bladder. That can lead to urinary retention. There are medications that are toxic to the kidneys. So nephrotoxic medications we need to be aware of, especially in patients who have decreased renal function. And then there are medications that change the appearance of urine. Phenazopyridine, which is like azo, it's a urinary pain reliever. Basically, it just decreases the pain associated with urinary inflammation. It turns urine bright orange. Amitriptyline may turn urine green or blue, and levodopa can make urine look very dark. Okay, we're going to look next at assessing the urinary system.